I think the bottom line is musculoskeletal imaging now is really getting to the point where MR is critically important, I think, in a wide area of musculoskeletal imaging. And I'd like to go through a number of different disease categories today, and also in a number of different joints and areas in the extremity, include a little bit about neoplasia, a lot about traumatic injuries, because still the most common injuries, really the extremities, are traumatic injuries, and there's a host of different types. So why don't we begin by talking about the knee. And I'd like to cover a little bit about meniscal disease, ligamentous injuries, and I'll say just a little bit about some of the miscellaneous conditions. Actually, by far the most common clinically significant injuries in the knee have to do with the menisci. Ligaments come a close second, and then there are a whole host of disease processes around the knee which can mimic these two more common ones, which actually, depending upon what other diagnostic procedures one uses, they can either be just as well diagnosed by MR or much better diagnosed by MR, or MR can be, in some instances, the only diagnostic study which can actually make the diagnosis. So MR can be very helpful in and around the knee. Now, just a little bit about technique. And all of what I'm going to discuss today and all the images I show, they will all be done by surface coils. And I think surface coil is mandatory in extremity imaging because we're looking for very fine spatial detail or anatomic detail which requires high spatial resolution. And we also need good contrast. And in order to get good contrast and good spatial resolution, one really has to have a very high signal to noise. And in order to get that, one needs a surface coil. Most of the images you'll see today were performed on a GE system. I think there are a number of systems that can do good extremity work, but they all need some sort of an extremity coil, and this is the one that we use, which is part of the GE system and is an excellent coil. Now, as far as the technique, there are a number of different people that like to use different techniques in the knee, and we've gone through a whole host of different techniques over the last 3 years. The one that I like best now for just general imaging of the knee, is to start out with doing imaging in the coronal and sagittal plane. Now, there are special circumstances where I also like to image in the axial plane, and that's predominantly disease where one is concerned about the extensor mechanism, the patellofemoral joint and the patellar ligaments. And also if there's a question of a plica, which we really won't go into today. But basically I like to start out in the coronal plane using a T1 weighted image, and I like to image in a 16 centimeter field of view and 5 millimeter cuts. And both of these are contiguous images. The first one on our machine, we do a TR600 or 800. It doesn't really matter. You just get a few more cuts with the 800. And it's an interlead program where we do 5 millimeter thick cuts which are contiguous with one another. Then we image in the sagittal plane, again 5 millimeter thick cuts, 16 centimeter field of view. But in the sagittal plane I like to use a long TR and short and long echoes. And I'll go through reasons why I like to have a T2 weighted image and imaging the knee. I think it's actually very important. We initially started doing this series for evaluation of the anterior cruciate ligament, and I think MR, if you just have T1 weighted images in the sagittal plane, MR is not as reliable as we would like for evaluating the anterior cruciate ligament. However, with the addition of T2 weighted images, acute disease of the anterior cruciate ligament, which means an acute tear, can be very well evaluated with MR. But there are a host of other diseases which we've also found the T2 weighted image to be helpful in the knee as well. Now, in the presence of acute trauma, we like to, in the coronal plane, do a 1500 TE 20 and 80. And the reason for this is the coronal image is the best image for evaluating the collateral ligaments. And in acute tears of ligaments, there is blood and a liquid extravasation in the area of the injury, and that's often better depicted on a more T2 weighted image. So we try to include an image that has a an intermediate or T1-ish type contrast with a more T2 weighted contrast to see the free fluid. Now, something that it took me a while to understand the importance of, and now I'm a firm believer in it, and that is photography is very important in evaluating the knee. And I think that we have been at fault in not pushing this more, and I think it's been a major area of how can I say, something that has been overlooked by other people as well. We like to photograph the knee in both soft tissue windows, and then we like to have very narrow window widths, magnified, high contrast views to evaluate the menisci. So we like to image all the images through the knee with soft tissue windows, which give nice, pretty images. And then we like to do a optic magnification by a factor of 2 and have very narrow window widths, which on our machine we have the window widths around 80 to 85, and just photograph the menisci. These images allow much better visualization of any signal abnormalities within the menisci than these images over here. And I think there really is a significant improvement when evaluating meniscal disease. I no longer even look at the menisci on these images, but I look at the rest of the knee on these images, whereas for looking at the menisci, I just use the high contrast images. And so the people in the back of the room can see the difference. These are the images that I really like to use to evaluate the menisci, and this type soft tissue image I like to use to evaluate the rest of the area of the processes around the knee. Oh, the other thing that I won't spend a whole lot of time today, but the hallmark of meniscal disease is going to be signal intensity within the meniscus. It should be nice and black. The majority of people that we image on a high field system is going to have signal within the meniscus. It's unusual to have a meniscus without signal at high field. That's not true at midfield. In the midfield range, the majority of menisci will not have signal. But to evaluate the intensity of the signal and the morphology, I think it's very important that you standardize, have rigid standards for the way in which the meniscal windowing is done. If you have a meniscus that has signal within the meniscus, if you vary the window widths and the levels, you can make that signal change its configuration. And therefore you really need to establish a set window width, which I think is very critical, and always do your photography with that set window width. Otherwise, you'll have a lot of variability in the intensity and the configuration of the signal you see within menisci, and it will be difficult for you to develop your own internal criteria as to what is significant and what is not significant.
You see the signal on the high field just due to the higher field strength and better resolution, better signal.
I think it's primarily due to the increased signal to noise that you have in a high field system. Maybe we could talk about that later if you would like. It would take a while to go into that at the present time. Maybe we can talk about it afterwards.
Criteria for normal and abnormal then be different on
Yes.
the field versus the higher field?
Yes. I'll make a comment on that in just a minute when I go through disease. I do believe that the criteria is different on the two. I must say, however, that I have not had nearly as much experience on a midfield system as I have on a high field system. So it's from a smaller data set that I make the recommendations at the midfield system. But from friends of mine that I've talked with and cases I've seen myself, I do believe that the criteria have to be different on the two. And I'll go into that specifically in just a minute. Now, I'd like to talk a little bit about the menisci and meniscal anatomy. This is a knee photographed from above that has been disarticulated, and this is the medial meniscus, and notice how it has a very large radius of curvature, and this is the lateral meniscus with a much smaller radius of curvature. The image on the right is right along the plane depicted by the spinal needle, and so what you can see is the posterior horn of the medial meniscus, and notice how much bigger it is than the anterior horn. And then you can see the medial femoral condyle, medial tibial plateau with a very characteristic champagne glass configuration, and the muscles and tendons. If we go to the lateral meniscus, notice how symmetric the posterior and anterior horns are. And this can be important because if you have a sagittal image and the posterior and anterior horns are not symmetric in the lateral meniscus, it means there's something wrong. It could mean that there is a cyst which is involving part of the meniscus, or it could be that the patient may have had an oblique tear where the central fragment has moved into the notch and you're not seeing it. Also, and probably more importantly, is on the medial side. The medial side, the posterior horn should be larger than the anterior horn. And if they are symmetric, that's abnormal, and one has to worry about the possibility of a bucket handle tear without definite signal changes within the meniscus. That's rare, but it's something that is worth mentioning, I think. Now, the hallmark of meniscal disease is increased signal intensity within the menisci. As I said before, we find that almost the vast majority of menisci have signal, especially at higher fields. So early on, we tried to develop some sort of a rough grading system which would help us try to distinguish the significant from the non-significant. And it's not always easy to do, but we came up with a grading system where we had 1, 2, 3. Grade 1 is irregularly configured signal intensity within a meniscus, but the important thing is that the signal does not communicate with a superior or inferior articular surface. We found that this type of signal intensity within the meniscus was rarely associated with meniscal disease at arthroscopy. So we consider this in older individuals to be a degenerative change within the meniscus, but it probably at the present time does not have a major clinical significance. Now, another signal that we saw was a more linear signal within the meniscus, which very frequently, characteristically, communicates with the capsular margin of the meniscus, but again does not communicate with the superior or inferior surfaces. In pathologic studies, which we did, or David Stoller did, we found that these in older individuals are central degeneration within the meniscus. And it's been well described previously. In younger children, however, under about the age of 10, this is the normal configuration, and this is the normal vascular supply which vascularizes the meniscus in children. We found in a series of 144 cases that was published last August in Radiology that these were rarely associated with meniscal tears as well. The hallmark of a meniscal tear is high signal intensity within the meniscus which communicates with one of the articular surfaces of the meniscus. Like in this particular case, we found in the pathologic series that we did that these were all associated with tears. Occasionally, if the communication is somewhat tenuous with the articular surface, these can be, in about 3 to 5% of cases, intrasubstance tears, which has been something that's been debated in the arthroscopy literature for some time, but are again probably significant. But if the arthroscopist is not aware of where the signal abnormality is and doesn't probe the meniscus in that location, it may not be visible at arthroscopy. And we've had a number of arthroscopists now find tears that they feel quite confident that would otherwise have been missed because they probed the area of abnormality that was on the MR scan. That is, those orthopedists who believe this. Not everyone does. So that's, I think, basically a capsule of what we've found of how we believe that the menisci can be best evaluated for the presence of meniscal tears. And there is some debate from other people about that, but we've had very good luck. And basically, our statistics come out, and we just finished a series that was presented at RSNA this year of 270 cases where, using that criteria, we had a 93% sensitivity and about a 92% specificity for meniscal tears using our system. So we think it's a very good system. Now I'd like to talk about some of the pitfalls, though, in diagnosing meniscal tears, and there are a number of them, and I'll just cover these one at a time. I'll start out with a little bit of anatomy, which is important, and that is there is a ligament which communicates, or which connects the anterior horns of the medial and the lateral menisci. And there are two potential pitfalls with this ligament. One is that if you have a cut through a meniscus, and quite classically it's a lateral meniscus, if you have a cut right through here, there is a ligamentous attachment between the anterior horn of the lateral meniscus and its tibial attachment, which is this, which characteristically has a fat plane right through the middle of it. And the next cut over, one would see a typical triangular appearance of a meniscus, but this is actually the meniscotibial ligament. And this kind of a signal in it is not abnormal. That's just a fat plane within the ligament. So one thing to be careful is on the first cut into what looks like the anterior horn of the lateral meniscus from the notch, you will normally be imaging the ligament and not the meniscus, and this kind of signal is quite normal. You really need at least 2 cuts which show this signal before you can be comfortable that there's a tear there. And normally you should see the more triangular appearance of a meniscus rather than this kind of lenticular form appearance which is typical of the ligament. Also, you have to be a little careful in that tears aren't all that common in the anterior horn of the lateral meniscus. And this is another situation. This actually looks like a tear, and initially we called these tears, but actually what's occurring here is that this is the anterior horn of the lateral meniscus. This black structure here is the transverse ligament. And if you follow in this patient this structure, you can go all the way through the notch and see it actually now communicate with the anterior horn of the medial meniscus. This is the transverse ligament, and in about 30% of cases there will be a cut which could be misinterpreted as a tear if one doesn't recognize the normal anatomy in this area. So there are 2 potential pitfalls around the anterior horn of the lateral meniscus. Now this is a situation of a grade 3 tear that we did in a cadaver. And notice how it's a little bit tenuous in its communication with the inferior surface. We disarticulated this knee, removed the meniscus in whole, and it looked entirely normal. We then sectioned the meniscus and did H&E staining, and right in the location where we see the abnormal signal here, there was a frank fibrocartilaginous separation, which was a tear, and this is the intrasubstance tear within the meniscus, which was initially described by Smiley back in the 60s as the earliest stage of the clinically significant horizontal cleavage tear. And these are the sorts of things that can be picked up by MR, and the orthopedist needs to recognize that if he doesn't see this on arthroscopy, especially if it's in the posterior horn, he needs to probe that area, and occasionally if he can't get in to see it well and probe it well, he may have to have a second posterior approach so that he can better evaluate that meniscus. And a number of our orthopedists using that technique have picked up tears that they feel that they would have missed otherwise.
Are those symptomatic?
Yes. Smiley first stated that they were symptomatic back in '60 in his early writings. It's a debated issue, and I'm glad you raised it. The reason that we think these are symptomatic are 2 reasons. One is we've had several patients with these now who had relief of symptoms immediately after partial meniscectomies. 2, if you take menisci with intrasubstance tears, their rheologic properties, that is, if you try to deform them, they will deform differently than a meniscus which is totally intact. And originally, for years it was thought, and it probably still is the case, that the major cause of pain in people with meniscal tears is the fact that under stress and strains, the meniscus buckles abnormally and tugs upon very highly innervated surrounding parameniscal tissues. That occurs both with intrasubstance tears and with tears which are complete tears which go through the surface of the meniscus. Secondly, in the last couple of years, Day and others have used more sophisticated techniques to do pathology of the meniscus and have found that the meniscus is actually an innervated structure. It's been known for some time that the peripheral third of the meniscus, even in adults, is innervated and is vascularized. And it's now quite well shown that along all of those vascular channels, nerves follow the vessels. And therefore, we now recognize that the meniscus is innervated, and therefore, intrasubstance tears can probably produce pain by direct irritation of the nerve fibers in the meniscus itself. So we are of the camp that believes that these can be very significant. Yes?
How do you separate the linear type 2 degeneration from the linear intrasubstance tear One looks a little thicker, you call it a intrasubstance tear. If it looks a little finer, you call it linear degeneration.
The way I generally do it and so far it looks like, both in the small pathologic series that we did, which was, by the way, published in June, I think, Radiology, if the signal goes all the way to the surface like this one is, I call it a tear. If the signal stopped right here and this margin, this peripheral margin, or the inferior articular surface of the meniscus was black, then I would say it's grade 2 tear. Now, I must say, so that's the way that I generally distinguish between what I think might be a significant tear from what I think might just be degeneration. In actuality, it's a continuum. And occasionally there will be a very bright grade 2 signal. And because it's so bright, even though the margin of the meniscus is black, I will hint in the dictation that it actually might be an early intrasubstance tear. And generally I call and talk to the orthopedist and tell him that that's the situation, and that if he's going to arthroscope the patient, that he probably should be very careful to probe in that area, because I don't think the tear is going to be a complete tear. If anything, it's going to be an intrasubstance tear that he'll have to find by probing. Again, I think all these criteria, I think, are helpful in trying to steer in the right direction. I don't think any of them are infallible, and I think we have to recognize that when we read the studies. Now, there are two types of tears that I would like to discuss in a little detail, because I think they're important and they can present very subtly by MR. One is the vertical longitudinal tear, called a bucket handle tear, and the other is a little radial tear located classically in the body of the lateral meniscus, which is called a parrot beak tear. This is a normal meniscus on your left. This is a torn meniscus on your right. This area of the meniscus is called the free edge, and here you can see that there is marked blunting of the free edge with high signal intensity right at the free edge. Now, it would be very easy to call this partial volume artifact, since you know that you're right at the very edge of something. And indeed, when I see this configuration, I know that there's going to be blunting of the free edge, and I'm concerned about a parrot beak tear, which is located in the mid-body of the free edge. But the coronal images now are very helpful. This is a normal coronal image in a normal patient here. Notice how sharp the free edge is. This is that patient with a parrot beak tear, and notice the signal intensity at the free edge, which actually goes a little bit into the substance of the meniscus here. This is a parrot beak tear. Now, these tend to be very small, and they very typically are only seen in one cut, and this is their appearance. Now, the importance of this is that when the arthroscopist sticks his scope in, the first thing he sees is that section of the meniscus, and so he can diagnose parrot beak tears very, very well, and it's a little embarrassing if you don't pick it up. They generally do partial meniscectomies on these, but there are some orthopedists who feel that the majority of parrot beak tears don't need to be even resected, and that some feel that these small little tiny parrot beak tears, patients may actually do better if surgery isn't performed. But I think that we need to be able to make the diagnosis. Yes, sir?
I'm afraid I don't see the parrot's beak. Could you describe that configuration?
Yeah, that's very good. The reason they're called parrot beaks is that I have a slide for this, but I didn't put it in. You get a little bit of an oblique tear right on the free edge here, and it starts on the free edge there, and it kind of goes into the meniscus like this. This little lip, this little attached fragment, so to speak, will then kind of fly in the breeze out here, and when you look at it at surgery or at pathology, it looks like the beak of a parrot coming down there. And that's why it's called a parrot beak tear. So it's just a little tiny tear here with a little lip or projection of the meniscus as it's partially detached here, which looks like a parrot beak sticking out from the meniscus. That's why it's called that. I'll show you why a bucket handle tear is called a bucket handle. I can do that. This is a schematic diagram of a bucket handle tear. It's a vertical longitudinal tear in the meniscus, and Typically, the central fragment will move into the notch. This is a cadaver, and right here is where the femoral condyle sat. This is the peripheral rim of the meniscus, which is the bucket. Now, you'll have to ask the orthopedist why they think that looks like a bucket, but that's what they call a bucket. And this is the handle, which is the central fragment here, which is migrated into the notch. So this is the handle, and that's the bucket handle tear. And on MR, we can see here is a vertical tear. This is in the anterior horn of the medial meniscus. If we go a cut back, you can see here is the bucket or the peripheral rim. Here's fluid sitting in where the meniscus should be, and here's the handle or the central fragment that is migrated into the notch. And so you can see it here. Now the one thing to notice is that in this particular patient with this huge tear, there is no abnormal signal really within the fragments of the meniscus. This was an acute tear, and we can just see separation of what otherwise could look like normal menisci. So the morphology of the meniscus is also important in looking at tears, especially the acute tears in athletic individuals who are young without a lot of degenerative changes. Bucket handle tear. And one other tear that one should be familiar with, this is a peripheral meniscal capsular separation. It's not really a tear through the meniscus itself always, but it can be a tear of the meniscotibial and meniscofemoral ligaments, which allows the meniscus to move too freely. And this is typically seen in the posterior horn of the medial meniscus on MR, where if there's more than a 3 millimeter separation between the peripheral margin of the articular cartilage on the tibia, which stops right about there, and the peripheral margin of the meniscus, if it's more than 3 millimeters, then that signifies a meniscocapsular separation. The importance of these, some of these, especially on the lateral meniscus, will heal spontaneously, but frequently in the posterior horn of the medial meniscus, they will not heal themselves always, and that meniscus will continue to be too loose. Trauma will continue to be traumatized and will degenerate. However, if one goes in arthroscopically, this tear can be very nicely and easily sutured, and it can repair itself, and it does not need a meniscectomy. And it's now been shown that knees that undergo meniscectomy don't do as well in the long term as knees that don't undergo meniscectomy. You follow the articular cartilage on the tibia, which is this gray line here, and here it's a little bit hard to see, but it stops right there, kind of right at the end of the tibia. So that's one point. The other point would be the peripheral margin of the meniscus here, and that distance right there is about 5 millimeters in this particular case, which is too much. This is a meniscus, and I'd just like to go through a couple of the cuts. This is a lateral meniscus, tibiofibrillar joint. Meniscus, it's kind of tall. Meniscus, meniscus, and meniscus. That's all the meniscus, and notice we don't see any of the nice sharp free edge that we saw in the other cases. This is a discoid lateral meniscus, and you can see how it really has, it's too thick, and it extends all the way through the joint space and totally separates the femoral condyle from the tibial plateau. And I don't have it here. The coronal scans can also be very helpful in showing how the meniscus does not have a typical free edge, but extends completely across the joint space. The importance in these is to determine whether they're torn or not. Most of the discoid menisci we have seen have been asymptomatic, and they've been in knees that have had medial meniscal tears. In that situation, the arthroscopist would like to know of the existence of a lateral discoid and also know whether it's intact or not. Most surgeons these days will not operate on a discoid meniscus unless it's torn. They'll take care of the medial side, look at the lateral side, and leave it at that. Now, one other disease process, kind of for completeness, is a perimeniscal cyst. Perimeniscal cysts are actually horizontal cleavage tears within a meniscus, which we can see here, that rupture through the capsular margin, and the fluid then extravasates into the perimeniscal tissues. This didn't come out very well, but this is a tear here, and this is a cystic collection out, in this case lateral to the meniscus. That's on the lateral side. They tend to be small and symptomatic. On the medial side, they can be huge, as in this particular case, very abnormal meniscus here. This is fluid coming from the meniscus, and these can become huge, 10, 12 centimeters sometimes. They dissect between soft tissue planes. and can sometimes be mistaken for a popliteal cyst. So those are cystic menisci. The important thing is that these require meniscectomy because the abnormality is an abnormal meniscus, whereas a popliteal cyst or some outpouching of the joint capsule is treated very differently. Now I'd just like to say a word about menisci that have been repaired. Now it's very common, and there's a big push now in orthopedics to, instead of doing partial meniscectomies, to actually repair tears and menisci. This is a patient that we can see had a very complex tear of the anterior horn of the lateral meniscus here. That was at diagnosis. The patient then had surgery, and this was sutured. 1 week after surgery, these are the corresponding cuts, here and here. It looks remarkably better. And in successful surgery, we've seen very good results like this. And this is now 2 months later, and notice that there is a little residual degenerative change. This patient was asymptomatic and has done very well with the meniscal repair. This happens to be one of the senior partners in our radiology group who came in with this tear, which we can see here. And this is abnormal posterior horn of the medial meniscus with a tear extending here, horizontal cleavage tear. He then underwent a partial meniscectomy, but we can see, and this didn't come out very well, I apologize for the slide, but we can see that there continues to be a cleavage, a tear here, which you could see on the films much better. And there's a very funny configuration of the posterior horn of the medial meniscus that looks like there's a loose tag of meniscus located near the notch, which is going into the notch, almost like the bucket handle tear that I showed you before. And now what I'd like to do is, with this up there, to get a feel for how arthroscopy sees things, I'd like to show this patient had a repeat arthroscopy, and right at the tip of the probe there is going to be a big hunk of meniscus, which is a big tag, which is pretty much free. See how it moves? It's actually quite, see that thing? That whole big tag was just connected to the meniscus by just a very small little peninsula, and it was free in the breeze, so to speak. And that tag right there is this abnormal piece of meniscus that is subluxing into the notch here. That's the appearance, that's the MR appearance. So he had because of the second MR scan, he was continuing to have symptoms after his first surgery. Because of this, the orthopedist did not want to take him back to surgery. He continued to be symptomatic, but he really didn't want to go and have another surgery 6 weeks after the first one if it wasn't going to help him. We did the MR scan, showed the surgeon what the problem was, showed the radiologist. They decided to have surgery the following day. He had surgery the following morning, which was a Friday, and he was up walking on his leg on Monday without any pain. It's now 2 months after this, and he is doing extremely well and is now off in India on a vacation.
Did they repair it or resect it?
They resected it this time, and this is actually post-resection. This time they actually took out a good piece here, and there's just a little tiny rim of meniscus left. If you look at this under the films, there's no abnormal signal within it. It has a funny morphology due to the surgery, but we said it was a very good response by MR, and he had a very good response clinically as well.
What about tibial plateau underneath?
This is subchondral sclerosis, and it's degenerative change. Now, I'd like to kind of go through fairly rapidly now the ligaments of the knee, because they're very important. Here's a lateral image in the sagittal plane. This is the lateral collateral ligament in the sagittal plane, the conjoined tendon here, and the biceps femoris tendon here as they come together. I realize that it's a little... I know most people here are here because they're interested in neuroradiology, so I hope I'm not boring everyone by going over these things. It's hardly neuro, but I understand. This is the lateral collateral ligament here seen in the sagittal plane. And notice how you can see it going from the conjoined tendon here to the lateral femoral epicondyle, and notice how sharp and normal the soft tissue planes are around it. It's a person who went skiing and took a tumble, and here notice you don't see, here's the conjoined tendon, can't even see the lateral collateral ligament. Notice how you've lost the soft tissue planes on the T2 weighted image. You can see the high signal intensity, which means it's an acute injury that has liquid extravasating into the tissues. Also notice that there is separation in the joint space itself, which means that it's a grade 3 total tear, and the joint is unstable. And if we just go one cut more anteriorly, because sometimes you like to see it in a couple of cuts just to make sure, you can see that at no point do we see the nice normal ligament. And again, the point of the tear can be very nicely seen here as a focal area of high signal intensity. And this can be very helpful to the surgeon, because he really would like to know ahead of time exactly where the tear occurs. And then he can plan his surgery. And we've been able to be very accurate in telling them that on the second echo image, because that's where we see the collection of high fluid, high signal intensity. The one thing I'd like to say is that we're most reliable in telling them the location of the tear if we do the MR within 2 days of the initial event. After that, this liquid and blood kind of permeates the whole area, and often the entire ligament will lose signal intensity, and this will become more diffuse, or the high signal intensity will be resorbed, and we're a little bit less accurate in determining the location of the tear, though we can still tell them that it was torn. The medial collateral ligament over here on the other side is on the more anteriorly located, and it's just a black structure, which uniform thickness from the the medial femoral condyle across the joint space to the medial tibial plateau. The one thing I would like to notice, for those of you who do arthrography, is that there is a bursa that does not normally filled at arthrography, which separates the superficial fibers of the medial collateral ligament from the meniscus itself. Therefore, in MR, it is normal to have a thin line of higher signal between the meniscus and the medial collateral ligament. That's not a small tear, a peripheral tear, which took us some time 3 years ago to convince ourselves that that's the case. That is normal. When you have a tear of the medial collateral ligament, again, you get thickening, some loss of the soft tissue planes, and increased signal intensity in the area of the tear on the first echo. On the second echo image, again, you see the high signal intensity and really the location of where the tear actually occurred. We think MR is very, very accurate at evaluating acute ligamentous injuries. So far, we've done about 6,000 cases, and we've been accurate, and well, not all those have had ligamentous injuries, but we've had several hundred ligamentous injuries, and we've been very accurate. The anterior cruciate ligament is the most difficult of all the ligaments to evaluate, however, and I think it's very important to have a second echo image, though I won't show too many of them here. The hallmark of the anterior cruciate ligament normally is this nice straight structure. It can be striated. That's normal too. Most tears, acute tears of the anterior cruciate ligament, have a focal area of high signal intensity on the intermediate and T2 weighted image, with a very abrupt cutoff between the area of the tear and the more normal ligament distally. Now, we've had some cases where the ligament has just been torn off and kind of sit down here in a droopy fashion. We've had some distal ones. We've also seen avulsion fractures instead of a tear of the ligament. There are a lot of different things that can occur, but 80% of them look just like this. Now, the problem occasionally is on a T1 or an intermediate weighted image, the proximal aspect of the anterior cruciate ligament is laterally located, and it really is right next to the lateral femoral condyle, which can sit back in this area, and you can partial volume the medullary fat in the lateral femoral condyle with the proximal aspect of the anterior cruciate, and it can look something like this. It actually looks different, and you can distinguish the two. But the T2 weighted image really helps. If you have a tear that's liquid, that's bright on a T2 weighted image. That's fat on a T2 weighted image if it's partial volume of the femoral condyle, and it gets dark on a T2 weighted image. Also, a T2 weighted image is helpful. The fibers, the normal collagen fibers, are dark on a T1, they're dark on an intermediate, they're dark on a T2. Sometimes, if you have a lot of synovial hypertrophy, the synovium around the ligament can be a lot like ligament on a T1 or an intermediate weighted image. On a T2 weighted image, the normal ligament is black, the synovial hypertrophy gets brighter, and you can really better tell whether or not the ligament is intact.
Question?
Yes?
Have you tried any GRASS T2 weighted images to see if that holds up, that you can identify ACL tears?
We have tried GRASS, and grass, I think, is very nice in a lot of areas of the knee. Basically, however, I've had enough situations where the variability in the signal, if you take the same disease process and you have a grass of a bunch of different cases, it just seems like the reliability of the signal changes on grass is not as good as it is with regular spin echo techniques so far. So I still feel more comfortable with the spin echo techniques. Partially it's because we continue to have more experience with those. I think there's still a lot of work that needs to be done in evaluating gradient echo techniques. And one of the beauties of the technique and one of the problems with the technique is there's so many different ways to do it, depending upon what flip angle you use, what TR, TE, and so forth, that you can get a tremendous variability in the kind of contrast that one obtains. And there may be right ways to do it and wrong ways to do it. So far, my experience, I just don't feel that grass is as reliable a technique as spin echo for a lot of different disease processes. I think for some it's okay. But the posterior cruciate ligament is always well seen. Normal shape and appearance, nice black thick structure. When it's torn, as in this particular case, you see a focal area of increased signal intensity. Again, you can see all kinds of areas. You can see it pulled off and flying in the breeze. You can see avulsion fractures. But this is the most common tear, posterior cruciate. This is kind of important because even though posterior cruciate ligament tears are rare, you'll see one of these for every 10 anterior cruciate tears. The posterior cruciate cannot be well evaluated at arthroscopy. And if there's a suspicion of posterior cruciate disease, that usually requires a different arthroscopic approach. Now, one thing I'd like to point out is that this is the normal configuration of the posterior cruciate ligament. This is an abnormal configuration. Look how buckled it is. Now, sometimes if you have a stretched anterior cruciate ligament from chronic disease and an unstable knee, the anterior cruciate ligament can look entirely normal if you look at it. But it's what either a totally torn anterior cruciate ligament or a lax anterior cruciate ligament will allow. It will allow the tibia to move forward with respect to the femur. And in the knee coil that we use, it supports the knee by supporting the calf, which puts force forward on the tibia. When it does that, it will cause, when the tibia moves forward, it may be very difficult to see that when you look at the ends of the bones, but it causes the posterior cruciate ligament to buckle abnormally. So this is a sign of anterior cruciate ligament insufficiency, either from a tear or from chronic stretching, like you can get from some meniscal disease and other things. And we found this to be very useful. Also, the surgeon will say, okay, you told me that there's a tear of the anterior cruciate ligament. Is it a total tear or is it a partial tear? Well, I have to tell them that we can't say that entirely unless we can actually see the fibers going through, and sometimes you can do that on a T2 weighted image. But what we can say is if there's abnormal buckling in the posterior cruciate ligament, that means the anterior cruciate ligament is not intact, and that means if it's an acute injury, it's most likely by far that it's totally ruptured. Whereas if this is normal configuration, we tell them, well, we don't know for sure, but it may well be just a partial tear because we don't see abnormal displacement of the bones. Now, surgeons will often say that they can determine this very well by the anterior drawer sign and Lockman test and so forth, and they can, but we've had a number of instances where we've been more reliable than even quantitative anterior drawer sign, which surgeons have. The reason for that, especially in athletes, especially in professional football players, is that despite the fact that muscular contractions is not supposed to be able to stabilize the knee all that well, it really can in very good athletes. And they can have total rupture of the anterior cruciate ligament and have a perfectly normal drawer sign unless they're under general anesthesia. And in those situations, we've found time and time again now that MR has been very helpful in making the diagnosis that wasn't so obvious from clinical grounds. Now, I just want to touch a couple of... Yes, sir?
Do you rotate or angle the knee for the anterior cruciate?
Yeah, we basically... Murray Riker, early on, stated that the best plane to image the anterior cruciate in is in the knee with about 15 degrees of external rotation. The best way to get that is to have the patient lie down in the machine and don't say a word to them about positioning of the knee. The normal person, when he lies on his back, externally rotates the knee about 15 degrees. If you tell him to put it in a rigid position and hold it there, because all you'll get is a blurrogram. Because when people try to keep the knee in a set position, they move without recognizing it. So the best thing to do is just not tell anybody about that and just have them lie comfortably. And that's been most reliable for us. Now, as far as I'm only going to touch a couple that I think are especially important of a lot of miscellaneous conditions around the knee. This is a person who has a fibular fracture from skiing, and this could be seen very nicely with plain films and everything else. And you can see separation of the joint space. On the other side, the patient ruptured the lateral collateral ligament, and the fibular head was all right. This patient, however, had a totally normal plain film. And we're just doing a retrospective study now of the first 600 cases of MR of the knee that was performed in Santa Barbara, many of them before I moved there. So it's just kind of a routine outpatient imaging center. And we've done 400 now, and so far of those 400 cases that have been referred, 13% of them have had clinically occult fractures. Now, we are trying to get the plain films on all of those. In a pilot study we did when I was at Cedars, we found of people with this disease process, 80% of the plain films are normal. I've had recently a number of cases sent to me from around the country of professional athletes where they found some funny signal in the bone and didn't know what to make of it. And those are people who had this kind of a fracture. And the important thing, this typically is seen in people, and this is a little bit later in the disease process. He actually had a medial collateral ligament tear here. You can see the thickening in here, but this is 2 or 3 weeks later, so it's starting to heal. Yes?
Did you say 13% or 13 of 400?
13% of 400 cases. That shocked me. I actually thought it was going to be very high. I thought it was going to be around 5%, which I would have thought was very high. But we're actually sitting down, and that's what it's coming out to. And it actually very surprising to me. I knew we've seen a lot of them, but I didn't know it was that amount. Now, this is what it looks like, and it's surprisingly how easy this is to miss if one isn't aware of it and doesn't look for it. Notice that this is the normal area. Notice all these linear areas of low signal intensity here, also the loss of signal intensity within the femoral condyle, and very typically on the other side of the knee there is a collateral ligament tear. The reason for this is this patient was hit here. There is therefore, before this ligament ruptures, this is a classic clipping injury in football, by the way. The patient was clipped from the lateral side. Before the medial collateral ligament ruptured, there was enough compressive force on this side of the knee to produce the bony injuries. And by the way, some people now, because the plain films are normal and nobody quite knows what to do about this, will call this a bone bruise, which I think is kind of not reasonable, and that it probably connotes the right type of therapy for it. And then the medial collateral ligament ruptured. Most of these we see without associated collateral ligament injuries, but many have either a contralateral collateral ligament injury and or an anterior cruciate tear. The reason these are important is a number. One is that there is a situation that orthopedists have known for a long time of having collateral ligament injury in a patient who continued to have pain on weight bearing after they splint the knee when there's no tugging or anything, when the collateral ligament is protected. They will then go in and scope the patient thinking that they've missed a meniscal tear, and the menisci look normal. And then there is no diagnosis in a patient who continues to have pain on weight bearing. Well, the therapy for collateral ligament injuries now is generally not surgical, except for rare circumstances in this day and age. They used to be surgical lesions. Now surgeons tend not to operate on collateral ligament injuries. Instead, they try to have very early and vigorous ambulation. The problem is if you have a fracture, and these are called stress fractures in orthopedic literature, if there's a stress fracture, you don't want to have vigorous weight-bearing ambulation of these patients. And especially, and they continue to be symptomatic also. So when this injury exists, now in our orthopedists, the rehabilitation for the collateral ligament injury is very different. They continue to have range of motion, but they restrict weight bearing to allow this fracture to heal. And very typically it takes 6 to 8 weeks, just like a typical fracture does. Of those initial pilot studies which we did at Cedars, 80% normal plain films, and all of those patients that we got back at 6 to 8 weeks for plain films, the delayed plain films were positive, showing little areas of sclerosis right along the fracture lines. Yes, sir.
Have you done any repeat MRs, and has there been a change in signal?
Yes. Yes. With repeat MRs, we find that very gradually over about a 2-month period, this will go back to normal in the few that we've done. My concern is, I think this may well be the precursor of avascular necrosis. And we are hoping to follow all of these patients now that we have found on this initial retrospective study, follow them over time to see what actually their prognosis is. I think the prognosis is virtually 100% complete repair as long as it does not involve the cortex or go into the joint. But I think there may be a small percentage which may go on to avascular necrosis because it's... actually, I may show that here. And anyway, this is the lesion. Acutely in the first couple of days, if you get a T2-weighted image, you see faint increased signal intensity along these lines. It doesn't blow you away, but it faintly becomes higher in signal intensity, which helps in knowing that that's the situation. This, avascular necrosis, can look very similar to this. And in a patient who comes in and you're concerned about that, I think the history is really the best way to differentiate it. If you have a T2-weighted image which shows that it gets brighter, that's terrific, and I think that reliably states that it's acute. But if you have these patients 4 or 5 days after the event, you typically don't see the higher signal intensity on a T2-weighted image. But if they had trauma, recent trauma, then this almost always is going to be a bone trauma. And I tend to call this now either a trabecular fracture, a bone bruise, or a bony injury, and leave it at that. But you have to let the orthopedist you work with know what this signifies. Originally, I kind of called it a fracture, and without letting both the patient and the orthopedist recognize what we mean by fracture, that's a little bit misleading. So let them know that the cortex is generally intact on these. Plain film's normal, but there actually is a bony injury. This is avascular necrosis. Notice how it has a very similar appearance. You don't really see the little fracture lines through it. And this particular patient had chronic pain that he's had over years. One other thing I'd like to show you, this is a type of osteochondritis dissecans. I'm just showing this because in osteochondritis dissecans and other fractures, what you want to really know, the orthopedist wants to know, is how to approach it. If the articular cartilage is intact, he does not want to approach it via the joint space by arthroscopy. If the articular cartilage is not intact, then he wants to go in and debride it so that there's no loose fragments which will produce degenerative changes. The best criteria that we found, and recently there was an article from I believe it was New York, which further confirmed our findings, is that on a T2-weighted image, if you see high signal intensity deep to the fracture fragment, the cortical fragment, that reliably signifies that the articular cartilage is not intact. And it changes the therapy when that's the case. Now, I'd just like to show an interesting case here before we go on to get off the knees, and I spent more time than I wanted on the knees. I apologize. This is a patient with a bone scan initially called negative, and someone with fever and pain in the left knee. Maybe there's a little bit of increased uptake on this side. Really, it's hard to say. It's called negative. The plain films had a very subtle abnormality, which was also called negative. This is the patient's MR scan. Notice this looks like it may be a muscle, but that's not muscle. Kind of high signal in here. Here, this is a young patient. This is the pericardium out here. This is the pericardium out here. The patient grew staph out of the bloodstream, and when a needle was stuck into this, you got pus out, frank pus. On the axial scans, this is the pus collection here and here, which is contained by the pericardium on the T2-weighted image. So this is a frank case of osteomyelitis with virtually normal plain films and a bone scan. This is just recent. We've had another case of chronic osteomyelitis where not only was the plain film normal, the bone scan normal, but the SED rate was normal. We saw high signal intensity that went across the physeal plate. I thought, well, maybe it could be a chondroblastoma or something. The biopsy showed a tough substance, but it actually came back as chronic osteomyelitis. Just very briefly, bone tumors. This is an osteoid osteoma, just to see what they look like. Typical symptoms. There's generally a little bit of inflammatory change in the soft tissues around these. And just for completeness, osteogenic sarcoma. The great thing about MR, as everyone knows, it's the best study for determining intermedullary spread. It's the best for determining spread in the soft tissues. It's the best for determining whether or not the neurovascular bundle is involved and how many muscle groups are involved. And basically, in any bone tumor now, before radiation therapy or limb salvage surgery, MR is mandatory, I think is the bottom line, and very few people. Yes?
As in the brain, can you tell the actual tumor from, other things like edema, and how do you know exactly?
Oh, terrific. Once you get out of the brain, MR is fantastic. In the brain, there have been a number of pathologic studies which have compared pathology with MR findings in extent of tumor, and MR outside of the brain can determine the margin of tumor, and is very reliable at doing that. Inside the brain, it's just not very good for the brain. What can I say? Probably it's because they're very different diseases, really. Probably inside the brain there really is no tumor margin. Tumor is probably very diffuse by the time it's diagnosed. And whereas you may get a margin on contrast enhancement, the actual tumor tends to go far beyond any contrast enhancement and probably involves most of the edematous area of the brain. Whereas in the musculoskeletal system there generally is a very sharp margination of the tumor. Now I'd like to get a little bit away from these, and this is something that we've seen a lot in Southern California as well as elsewhere in the country. People like to run a lot. This is a young lady who's just started running and decided to run more than she should when she first started out. Developed severe pain and weakness in the distribution of this abnormality. Surgeon was concerned about a rupture of a muscle and whether he should operate. This is just a typical hematoma, intramuscular hematoma, and the important thing is that these heal fine on their own. Just keep the surgeon out. And we've seen a number of these, and we've actually kept the surgeon out on a couple of occasions where he was going to go in to operate, and we could tell him that the actual muscle is intact, that in 2 weeks she'll feel much better. Very typical appearance. On a T2-weighted image you could see the actual fluid level there. Now, I'd like to go to the shoulder, because I think the shoulder is another area where MR is going to be very useful, and I'll try to just go through this rapidly. For people that have round surface coils, despite the fact that every engineer in the world and every electrical engineer and every serviceman on your machine will tell you cannot do this to a surface coil because it has to be placed orthogonal to one of the gradient coil axes, humor them, but don't follow their advice. This is especially with GE system. I've found by far the best use of this coil is to stick the humeral head through the center of it like this and put it at a horrendous plane with respect to the gradient coils, and you get the best image. We're experimenting with some other coils now that I think may be advantageous, but they have their own drawbacks. This is kind of a sleeve coil that you put the arm through and put it in this position. It's tricky positioning these coils, and we're trying to develop a jacket that looks pretty to put this in, and also is a foolproof positioning device for the technicians. And this is very nice. I'll show some of the advantages of this in just a second. Now, as far as imaging the shoulder, I think it's really mandatory to image an oblique coronal plane which is along the axis of the supraspinatus muscle, as you can see here. And the image to the supraspinatus muscle looks like this. This is the muscle body. This is the musculotendinous junction, very important landmark. It should be at the 12 o'clock position. This is the tendon itself and should be nice and black with a uniform thickness. This is normal. Also notice that there is a fat plane which is underneath the acromion here, which is intact in this patient. Now, Now, if we go more posteriorly and follow through here, we can see that this is the teres minor and the teres minor and infraspinatus muscles here, which are two of the muscles and whose tendons make up part of the rotator cuff. This is the supraspinatus, come a little bit more anteriorly. It's kind of supraspinatus, infraspinatus, teres minor all together here. Now we're anterior enough to see supraspinatus coming across here. If we go more anteriorly, this is the subscapularis, which comes out from here, comes anteriorly and attaches anteriorly onto the humeral head and creates the anterior part of the rotator cuff. A little bit of anatomy. Now, in evaluating the shoulder, I like to use a concept which I think might be right, but I'm not entirely sure it is. And that is that the disease of the shoulder that we're interested in is basically rotator cuffs. But rotator cuff injuries, the majority, start out as impingement. And the impingement is normally due to one of two factors. Either an acromion that rides too low, like we're seeing here. There's very little space between the acromion and the humeral head, and that's because the acromion is too low. This is the level of the distal clavicle, and the acromion, it dips down too low here, and therefore there's less space. Notice that there's no fat plane to what you said was normal before, above the supraspinatus muscle and tendon. And this, or the patients can develop tremendous callus at the AC joint. And the callus can dip down and impinge upon the superior aspect of the supraspinatus muscle, as you can see in this patient on the right. Again, loss of the fat plane. Now, then you look at the supraspinatus tendon. It's too thick here. You don't see the nice planes that I showed you before. And in this particular patient, it's not black like it should be. It's still a little bit thickened, and it's not black. Okay. These are two patients that have impingement. And with impingement, when motion, you traumatize the supraspinatus muscle and tendon, and that leads to tendinitis. Tendinitis looks like this or like this. Areas of increased signal intensity within the tendon and some swelling of the tendon. As the tendinitis progresses, there is a continuum into small partial tears. From small partial tears can look just like we're seeing here. So I don't think by MR we can distinguish tendinitis from small partial tears. But what I think is important to the surgeon may think otherwise, is first we've got to decide whether the rotator cuff is abnormal. If the rotator cuff is normal, then we can tell the surgeon that we don't think that the patient's symptoms are due to the rotator cuff disease. And that's actually important. And that's actually something that's not easily determined otherwise. Once we can say that it's abnormal, then we have to decide really what's going on. Well, one thing we can do is to see if there's significant impingement. Because if there's impingement, then we can tell the surgeon the actual cause of the problem, and then the surgeon can decide whether he wants to go in and do an acromioplasty or go in and shave off the callus, which is something he can do to relieve symptoms and also prevent the development of a more debilitating rotator cuff tear before it occurs. Now, determining impingement cannot be well done by other techniques. MR is terrific for doing that, and that is a terrific advantage to the surgeon. The next thing we can do, if the disease process is tendinitis or partial tears, then the treatment usually is decreased motion, treating the impingement if the surgeon decides it needs to be, and anti-inflammatory drugs. Generally, a lot of surgeons will not want to go in and operate on the tendon if it's just a small partial tear or tendinitis. Now, if that continues to progress, however, then you can get proximal retraction of the supraspinatus muscle, fatty degeneration. Notice how it's dipped down in an abnormal position here. The musculotendinous junction is way over here, not at the 12 o'clock position, it's way over here, and this is a huge tear of the rotator cuff with proximal retraction of the supraspinatus muscle. At this point, it's difficult to repair because the other thing that MR can do is tell the surgeon roughly how much separation there is in the tendon tear, which he would like to know before he goes in for surgery. And in cases where there's a lot of fatty degeneration, very often this muscle is not stretchable enough to really bring it back and create a good repair. And this is someone who's had multiple surgeries because of that. And on a T2 weighted image, we can see fluid in the area of the tear. And that reminds me, as far as protocol, what I like to do and I can't guarantee you it's the best way to do it. It's just something we're trying at the present time, is to start off in the coronal plane, 5 skip 0, TR 1500 2080 images, 2070 images, 128 by 128 matrix, 2 excitations with the GE system, and you have to convert that into other systems that you have. Now the
What was your thickness? I'm sorry.
5, I like 5s. Then I like, I'm sorry, sir?
Why 5 instead of a thinner cut?
Notice I like 5 in the knees as well. A couple of reasons. Actually, as I said before, it may not be best, and I would encourage people to experiment with the thinner cuts. The reason I generally like to go with the thicker cuts, and it may not, in this particular place it may be wrong what I'm doing, is generally get better signal to noise and better contrast differentiation. And the reason I like to do it in the knees is it's the way we do knees, patients can be in and out of the machine in 20 minutes reliably. If you go to 3 millimeter thick cuts, it requires additional pulse sequences if you do the T2 weighted type sagittal images that I have, and it increases the time in the machine. Plus we have done images in the knee doing both 3 and 5 millimeter thick cuts on the same patients, and what we actually found out is that we had a slightly better statistics with the 5 millimeter thick cuts than we did with the 3s, though there were a few patients which were better done by the 2 different techniques, but in general we thought the 5s were better doing both in the same patients. I have not done that study on shoulders, and in the coronals especially it might be better to do the thin cuts. In general I prefer the little thicker cuts because I think when we're dealing with the disease process, as I gave you my bias here, spatial resolution isn't all that important. You just need to be able to see that tendon, and I think we can see it pretty well with, I've been very happy with 5s.
No skip, did you say?
No skip.
In that case, then, are you inferring a tear because of the abnormal position of the tendon?
Yeah.
Or you're not actually seeing the tear itself?
Oh, this tear is so big. We are actually. This is the proximal end of the tendon there. The distal end of the tendon actually is right there. That's all tear from there to there. Now, how do I know that more comfortably? On the T2 weighted image, if we went through all the different slices, we could see that this area is full of all high signal intensity. And the other thing is that this is just the configuration of the distal end of the muscle, how it narrows down to the tendon here. And that should be right up there. So that also lets me know that that's the tear itself. I mean, this is a huge one. Then I feel that we can reliably say there's a tear when we see this proximal retraction, even if it's only a small proximal retraction, especially if there's a fluid collection in that location. Here we can see there's no tendon going through this area of fluid collection, so we know the tendon is not intact at that location. And that's why I think the second echo is helpful. I find the second echo to be helpful rarely in this disease, but when it is, it's very helpful. Most of the time, I just look at the first echo. If we're looking at impingement, if we're looking at higher signal intensity for partial tears or tendonitis, the first echo is really, or even a T1 weighted image would be the best. And I think another way to do this would just do T1 weighted images through here and forget about the second echo, because this only helps in gross disease, but in gross disease you really don't need to help all that much. So if it saves time on your machine to do just a T1 weighted image, I think you could just do T1 weighted coronals. But I think axials are very important in the shoulder. Very important. And so the next thing we do is an axial series of a TR2000, TE20 and 80. I like to do these 5 millimeters thick, and I like to do them at a 256 by 256 matrix. Sorry. I like to do 2000, 2080, 5 millimeter thick, 2 excitations, 256 by 256 matrix. That's
gap?
what?
How much gap?
How much gap? 5 skip 0. Now, don't etch that in stone, and I think if you really should try around, because I haven't tried enough techniques to really feel that this is the best one. And I think one should look at it, and I think thinner cuts should be looked at here as well. The reason, what one looks for, or what I think one should look for in the axial cuts are several very important structures. One is the glenoid labrum. This is the anterior glenoid labrum. This is in a normal. Notice how triangular and how sharp the point of the glenoid labrum is. The other thing to look for is the long head of the biceps tendon. You can see it very, very well by MR in this plane. Here, and one of the reasons I get the T2 weighted image is to look for fluid around the long head of the biceps tendon. You can also see a lot of other anatomy and around the shoulder as well in the axial plane, but these are the main things I'm looking for: the glenoid labrum and the long head of the biceps in the axial plane. This is a case I got surgical correlation on not too long ago, and I just did these slides 2 nights ago, and I thought they would project better than this. This is an abnormal anterior glenoid labrum. Notice there's a high signal area right through here. It's deformed in that area. And this is the same patient, and I'm sorry these didn't turn out very well. If we have one cut farther down is what you see. This is a little triangular piece of dark glenoid. I know you can't see it from there. I really apologize. And this is part of the glenoid labrum, but there is a bright area separating the two. This is a patient who surgically had a large, what the surgeon called bucket handle tear of the glenoid labrum. Again, it's what there was. I guess this would be the bucket in this case, and this would be the handle out here, but it was a large tear. Now, I've seen this kind of configuration on just one cut, and it's what those turned out to be were small tears. So even if you sit on only one cut, this is abnormal, and so far, in a few cases, not a huge number of cases, that's always been associated with a tear of the glenoid labrum. These are a couple of other tears, a big tear here. And this is the same patient. You can see high signal intensity in the location of the tear and some fluid in the joint here and a blunted margin. Oh, this is a patient that kind of has a sharp point of the glenoid labrum. This is a patient on a T2 weighted image where you can see the very ratty tear of the glenoid labrum here, and where the cartilage should be, we see fluid in here on this T2 weighted image. But not everything in the shoulder is labral disease. This is an old scan. This is one of the first we ever did, and we put the coil in the wrong place back here on the back, which is what GE told us to do. Whatever. Anyway, this happened to be a soft tissue sarcoma that was back producing pain that was thought to be shoulder pain adjacent to the scapula. Now, I think my time's up.
Could I ask you a couple
Yes.
questions about technique?
Yes.
Do you use respiratory compensation? I've had a lot of problems with respiratory artifact on those axials.
No, I don't. And we early on had a lot of problem with respiratory artifact too. And I have not found respiratory comp to be very useful. It's what I find to be much more useful are a couple of things. One is the positioning of the arm is very important. We used to always position the arm, as have many other people, in fact it's in the literature, as placing the arm over the person's belly. Well, the belly moves when people breathe, and that motion is then transmitted to the shoulder. So the most important thing is to make sure the hand is not in touch with the belly. So it's what I like to do is take the hand, put it palm down, put it on the side of the patient up on a little pillow so that the humerus is parallel to the ground, but that the arm is not touching the body. The other thing, and that eliminates 90% of motion artifact in our experience right there. Now the other thing that can be helpful a little bit in patients where there still is some motion artifact is if they lie a little bit onto the side of their shoulder, then the shoulder is stabilized by the table. And some patients, that will decrease any residual motion artifact. But we don't use respiratory compensation, and we reliably get the quality of images that I showed here. These were not especially pretty images.
Is that the general purpose coil, or is it the spine coil that you're
It's the general purpose coil that we're using. Actually, we haven't really experimented much with both of those. You might want to try both and see which one works best. But we use a general purpose. Actually, most of our imaging now is with that special sleeve coil. It's slightly better for looking at the glenoid labrum, but it's not enough better where I'd worry about it, as long as that other coil is placed the way I like placing it. And again, you ought to experiment and see if you agree with me. You may not. Yes?
So then you just stick the shoulder into the hole in the coil, which doesn't have any specific anatomic location, and then from the localizer choose the proper
Angle, yes.
anatomy.
We do a real quick axial localizer scan. I think it's a TR 300, 128, 128, TE20, one excitation image. It takes about 50 or 60 seconds. Large field of view, which this will change all. That's what we do right now because of the software that GE has. Very soon the software is going to be changed, which will allow us to do the high-resolution axials first. Use the high-resolution axials then to determine the coronal plane, so that we don't have to waste time on a scout view. I don't like doing scout views. But right now, the software which we have from GE does not allow one to use an off-center field of view axial image to do graphic prescription. And therefore we do a big field of view image to get the proper plane, use graphic prescription because there are less tech errors when the graphic prescription is used to do the angled coronals, and then we come back and do the high resolution axials. Present time. Now, there really isn't much time. I don't have a whole lot to say about the rest of the joints really, except in the wrist. There are a lot of different ways to do it. These are not good ways to image the wrist, because this is virtually an impossible position for anyone to hold who's alive. This is a little better in young people, and older people it's still impossible. So this is a nice technique which you can do now with angled cuts. You can have the arm up by the head or even down by the side with the anti-wraparound software, which a lot of GE systems have and others have as well. And both of these can be used. Generally, I found this one to be the best because there's still a little wraparound from the body and some motion artifact from the body, which will occasionally degrade images when they're at the side like this. But this works out well. We found the most important thing in all of joint imaging is to make sure the patients are comfortable. If the patients are uncomfortable with their arms above their head, this is the typical scan. If the patients are comfortable without doing anything fancy, this is the typical image quality. This is the median nerve, and I don't have time to go into it. There have been several papers now on the evaluation of carpal tunnel syndrome using size criteria and thickness of the aponeuroses here and other things. I just don't know how good it's going to be. All the studies are limited, but it's something to look at if you have certain people who are interested in carpal tunnel syndromes. Other planes can be very nicely imaged with the tendons. This is probably one of the best planes of all, and you've probably seen there have been several articles in the literature discussing evaluation of the joint spaces, especially if you put water or something in after arthrography. This is very good for difficult fractures to determine by plain films. MR, again, is the best technique there is for fractures, I think. And for hamate fractures especially, this can be very useful. For avascular necrosis, Kienbach's disease, and so forth, I think MR can be very useful. This is just a patient who had pain around the wrist, was thought to be kind of a semi-croc. We imaged him and had some problems with tech, but we could see a large area of abnormality here. And one thing, if you do a lot of joints that have very, very complicated anatomy in them, the first thing that I like to do is go through to see if I see any areas of high signal intensity on the second echo image that's not on the first echo image. When you see this, that's something that's bad, and you go from there. And that's actually been fairly helpful. We've looked at ankles. Several people have looked at Achilles tendon. This is what a chronic Achilles tendon tear trauma looks like. This is the normal side. It gets big but stays black if it's chronic. If it's acute, you see in acute tears, you see high signal intensity in the area. And this is a marker we use. It's just a little makeup container thing that's made out of plastic that we put peanut oil in. And it's very helpful in doing imaging. You just tape it onto the body in the area of interest, and then you know where to look. This is a patient who had a very interesting, again, doesn't look like much on the first echo, bright on the second echo, got to get worried. This is a patient. Here you can see fluid along the tendons, and this is pigmentovenous villonodular synovitis of the tendons. And let me just, there's one other case I want to show. This is a patient who's an x-ray tech in our institution, hurt her elbow 2 years ago when she was lifting a patient onto the floor table. And has had trouble with the elbow ever since. Recently she's been treated with very, very small doses of anti-inflammatory drugs, and 2 physicians told her they didn't want to see her anymore because they thought that she was a crock trying to get workman's compensation or something. Out of desperation, she asked me if I would please image her elbow, and the first person who looked at this said it was totally normal. Then I looked at it, and it's what one can see. Again, this is on the extensor. This is where all the extensor tendons of the forearm come up to insert upon the lateral epicondyle. Low signal here, bright signal here. This is focal area of fluid collection here, and this is basically chronic tendon elbow, tennis elbow, tendonitis. And I think she's going to end up having to have surgery. The final way to treat this is to sever it and reattach it, and I think she's going to come to that. But she actually was in tears when I told her that there was actually something wrong there, and she could go and tell those other doctors that, here, it's wrong. Thank you. And sorry I went over time.